We are live.
A very good evening to one and all, and welcome to the 118th episode of the AIOS ARC program. And this is for our postgraduate program, which is with a difference. And today we have a journal club. So we are very honored to have with us our esteemed discussants, Dr. Suhas Haldipurkar sir, who is the medical director, Lakshmi Eye Institute, Mumbai, but I think he has another urgent commitment today. Dr. Jatinder Bali sir, who is from Hindura Hospital, Delhi, and Dr. Srini Adaklan, who is the Chief Cataract Surgeon, Malaria Eye Care and Mantrust Eye Hospital, Telesari. A very warm welcome to all our discussants. We also have two presenters and their mentors here with us. So the first presenter is going to be Dr. Snehita Manohar, who is a junior resident at the Jawaharlal Nehru Institute of Postgraduate Medical Education and Research, Puducherry, and her mentor, Dr. K. Ramesh Babu, who is the professor and head, Jawaharlal Institute of Postgraduate Medical Education and Research, Puducherry. So, friends, this journal club is very close to our heart and it's a very nice way for our postgraduate training. I'd like to request our first speaker, our presenter, Dr. Snehita Manohar, to please give her presentation. Yes, we can see your slides. Just go on the first slide. Make it full screen. Yes, thank you. Yeah.
A very good evening to all the respected dignitaries and my fellow colleagues. I am Dr. Snehita and I'll be presenting the Journal Club today, moderated by Dr. Ramesh Babu sir, the Professor and HOD of Department of Ophthalmology, JIPMA. And I'll be presenting the Journal Club on the article Management of Refractory Persistent Epithelial Defect, Treatment with Topical Insulin, an Indian Pilot Study by Parul Jain et al., which was published in the Indian Journal of Ophthalmology in the year 2025. Coming to the definition, persistent epithelial defects are non-healing corneal epithelial defects for more than 2 weeks despite treatment. So the causes include neurotropic keratopathy, chemical injury, post-keratoplasty status, trauma, inflammation, and ocular surface disorders. The conventional management still remains lubrication, bandage contact lenses, punctal plugs, and autologous serum. The insulin and the eye. As we all know, insulin is an FDA-approved drug with proven safety, efficacy, used by the maternal fraternity since the 1920s. It is a cost-effective, non-invasive, and easily available alternative to the currently available novel modalities for treating refractory PED. So there was an article which states the identification of insulin in the tear film and the insulin receptor and IGF-1 receptor on the human ocular surface, that is the conjunctiva, given by Eduardo M. Roca in the year 2002. So topical insulin has been proposed as a novel therapy promoting epithelial regeneration. Use of topical insulin to normalize corneal epithelial healing in diabetes mellitus was mentioned in this particular article, where they had used topical insulin in diabetic rats to see whether there was wound healing. And there was a significant improvement in the epithelial defects as seen in the image here. So there was improvement by re-epithelialization, corneal sensitivity, DNA synthesis, and there were no systemic side effects noted, which was safe for ocular use. The mechanism of action of the insulin is depicted in the image shown here. As we can see, there is a persistent epithelial defect where the insulin first acts on the IGF receptors and decreases the level of IL-1, which is an anti-inflammatory action. It also increases the EGF, the epithelial growth factor, the platelet-derived growth factor, HGF, the hepatocyte growth factor, and the KGF, the keratinocyte growth factor, which will in turn improve the epithelial cell regeneration, migration, and promotes healing. And also we can see the quiescent keratocytes, which will get converted to activated keratocytes, and then which will get converted to myofibroblasts and promote in the extracellular matrix formation. So all these together will help in the corneal nerve regeneration as well as the epithelial healing. So insulin acts as a growth factor, stimulates epithelial cell proliferation, enhances cellular metabolism by increasing the glucose uptake by epithelial cells. It enhances the production of hemidesmosomes and basement membrane components, resulting in a better epithelial stability. It has an anti-inflammatory action, as I mentioned earlier, by decreasing the IL-1 and improves the epithelial surface integrity, leading to a better tear distribution. Oops, I'm not able to. So I'm not able to move next. It stopped actually. 1 second. So I'm not able to move to the next
Press the
slide.
escape. Press escape.
Yes, sir, but I'm not moving now.
Okay, so it may be some sort of a bandwidth issue there. Do we have this with the admin support? Have you mailed your presentation to the admin?
No, sir. Actually, I selected this.
Since your voice is coming out fine without any breaks, sir, most probably.
Now it came, sir.
Yeah.
Yes, sir.
Yeah.
It was used to evaluate the safety and the efficacy of topical insulin in refractory PEDs to assess its role in preventing complications and need for surgical intervention. So this study was a prospective interventional pilot study, which was done in the Guru Nanak Eye Center, Maulana Azad Medical College in New Delhi. 22 eyes were taken as a sample size with refractory PED, that is the epithelial defects persisting for more than 2 weeks. And the follow-up was up to 6 months after the treatment cessation. The ethical committee approval was obtained and also the informed consent was obtained. So the inclusion criteria was the patients more than 18 years of age, both diabetic and non-diabetic, with persistent epithelial defects which are refractory to conventional medical treatment with preservative-free lubricants and bandage contact lenses. So it was depicted in a pie chart as shown here, where 45% of the patients were those with corneal transplant and the 36% of the patients were the persistent epithelial defect patients who were in the etiology of neurotropic ulcer, and 14% of the patients were chemical injury patients, and the other 5% were the neuroparalytic patients. The thing to be noted here was they were not divided into subgroups under neurotropic ulcer and neuroparalytic ulcer. The exclusion criteria mentioned in the article was infective etiology on corneal swab, immunosuppressed status, lid abnormalities like entropion, ectropion, and trichiasis, pregnant and breastfeeding females, and those patients who were unable to comply with the tests or follow-up. This was the methodology which was used. The regular insulin, which was 40 international units per ml, was taken. In that 0.25 ml was taken, which implied it is 10 international units. This was diluted to 1 international unit per ml in a polyethylene glycol base. This prepared solution was refrigerated and was used within 1 month. The dosage given and instructed to the patients were 1 drop, which was instilled 4 times until there was complete epithelialization. The assessment which was done in the follow-up visits were the best corrected visual acuity using logMAR units. The slit lamp photography was taken for measuring for seeing the defect size. The ASOCT for assessing the thinning or the depth of the defect. And a random blood sugar test was done at the initiation of the treatment and then after 24 hours to monitor any change in the blood glucose levels. The follow-up was weekly up to 4 weeks. In case the defect did not heal within 4 weeks, it was followed up weekly until healing occurred, and then 6 months after the cessation, there was the follow-up because to look for recurrence. So the outcomes measured were complete healing of the epithelial defect. If not completely healed, they looked for the size of the epithelial defect and the best corrected visual acuity. These were the failures that were mentioned in the article. That is, when there was no objective improvement or improvement of less than 0.5 mm within 2 weeks, it was considered a failure. When there is an increase in the size of the epithelial defect or worsening, it was considered a failure. And whenever there was a need for surgical intervention, like amniotic membrane transplant with or without tarsorrhaphy, it was considered a failure. The statistical analysis which was used in this article were the SPSS V25, which was the software which was used to analyze the data. The normality was checked with Kolmogorov-Smirnov and Shapiro-Wilk test. The pre-treatment versus post-treatment were statistically analyzed using paired t-test or Wilcoxon signed rank test. And the qualitative data was compared by Fisher's exact test. And p-value of less than 0.05 was considered statistically significant. So this is a tabular column summarizing the data used and the statistical analysis used. So for measuring the visual acuity pre-insulin versus post-insulin, which was a continuous but a non-normal distribution type of data, they had used Wilcoxon sign rank test. And the size of the epithelial defect pre and post-insulin, which was a continuous and a normal data, they had used paired t-test. And the time-to-time healing analysis post-PK versus neurotropic ulcer, that is categorical comparison, was done using the chi-square test. This was a univariate analysis table showing the association of different factors with delayed healing after 30 days. The important point to be noted here was the p-value was insignificant. It was around 0.22, 0.90. So this just meant that either the age, nor the etiology, nor the area of presentation or BCVA had any influence on the delayed healing after 30 days. This was a multivariate logistic regression analysis showing similar results like the univariate analysis, but the p-value was insignificant, showing that there was no factors which was influencing the healing. This was an important bar graph discussed in the article where there is a green bar and the blue bar which is present. The green bar represents the delay in the onset, delay in the time of diagnosis. That is from the time of diagnosis to the time of starting of insulin. And the blue indicates the time after starting insulin, what are the time taken to heal the defect completely. So here we can see the delay in diagnosis, that is the time of diagnosis till the starting of insulin. It varied from around 7 days to 20 days. But the thing to note here is, despite variability in the pre-treatment delay, most patients achieved epithelial closure within 2 to 6 weeks after initiating insulin drops, demonstrating that a consistent healing response is there once the therapy began, despite however late we started the treatment. So this was a complete data sheet of every subject with etiology, the age of presentation, then the BCVA and the area of presentation. The things to be noted here was the systemic status, that is neither the hypertension nor diabetes, or if the patient had no comorbidities also, it did not influence the healing rate. And the BCVA pre-treatment and post-treatment all had shown improvement. And out of all the cases, 3 patients had complications. One was the post-PK, which had infection, and the other was the chemical injury, which showed severe thinning. And also the etiologies, as I mentioned, the 4 etiologies were given here: the post-PK state, the neurotropic state, the chemical injury, and the neuroparalytic state. And the age group varied from around 20 years to around 80 years. So these are the images which was given in the article, which shows this was the persistent epithelial defect which was present in the case of this was the persistent epithelial defect present in the case of post-PK. At the end of 3 weeks, all of them had shown significant healing response. This was the persistent epithelial defect in the case of chemical injuries. Those patients are also shown significant healing response at the end of 3, 4, and 6 weeks as shown in the image. These are the 2 complications I had mentioned earlier. One was the case of severe thinning and the other was the case of infection. So this had occurred in the case of chemical injury, persistent epithelial defect, which resulted in severe thinning, and the patient was taken up for multi-layered AMT. And in the case of post-PK PED, the patient had developed infection. This is the consolidated images of all the etiologies. And these were the 2 complications which were seen, that is the thinning and the infection. So the complete re-epithelialization in the days, etiology-wise was mentioned, which was around 21 days as a mean. So the results overview here are, the mean age of presentation was 50.5 plus or minus 14.5 years, with 18 males and 4 females. And the etiologies include post-PK, neurotropic ulcers, chemical injury, neuroparalytic ulcers. And the mean persistent epithelial defect area was 13.17 plus or minus 9.7 millimeter square. Complete healing was seen 77.2% at the end of 1 month and 86% at the end of 6 weeks. The mean re-epithelialization time was 21.5 plus or minus 8.8 days. And the BCVA had shown significant improvement from 1.1 plus or minus 0.2 to 0.8 plus or minus 0.3 logMAR units with a p-value which is significant, less than 0.001. So the strengths of this study is that there was a high healing rate, that is of 86% within a very relatively short period of 6 weeks, with an average re-epithelialization time of 21.5 days, suggesting that topical insulin is highly effective. And also, this demonstrated good ocular and systemic tolerance with no observed changes in the random blood glucose levels in either diabetic or non-diabetic patients. There was 0 recurrence and there was improved visual acuity as well. The cost effective and it's easily available when compared to the other factors like the recombinant nerve growth factor. And this was also a prospective interventional study. So these are the 2 studies. There were many studies which were compared here. And one was the comparison of the efficacy of topical insulin with autologous serum eye drops in persistent epithelial defects of the cornea, which was given by David Diaz-Valle and published in 2022. And also there was in vivo evaluation of the corneal nerves and epithelial healing after treatment with R and GF factor for neurotropic keratopathy, published by Leonardo in the American Journal of Ophthalmology. So this was a comparison of the present study which was given with the other studies. So here we can see the present study had used 1 international units per ml topical insulin, which is comparable with the Dias-Val et study, which has also used topical insulin with a similar sample size of around 21 and 22. And the etiology had a slight variation of infectious keratitis in the case of the other study. The area of PAD also was bigger in the case of Dias-Val et al., but the time taken to heal is 21.5 plus or minus 9 days in the present study, whereas it was 34.8 plus or minus 29.9 days in Dias-Val et al. Study. And the PAD recurrence was very high in the case where autologous serum was used. And there was topical Sani-German, which was used in Mastro Pasco, which showed 100% re-epithelialization. So the study limitations were, it is a small sample size, only of 22 eyes were included. No control group for direct comparison was present. It was a short-term follow-up for about 6 months only. And it is a single center study which took place in Mamsi, and the etiology heterogeneity was present. So the conclusion here is topical insulin, that is 1 international unit per ml, is a safe, cost-effective, non-invasive agent for refractory PEDs. It achieves rapid healing with no recurrence or systemic side effects, and its potential to become a first-line therapy pending larger randomized trials. The take-home messages here are topical insulin promotes corneal epithelial healing safely and efficiently. There are no adverse ocular or systemic effects, and it needs larger randomized control trials for definitive recommendation. So the reporting guidelines for main study types are mentioned here. This being a non-randomized interventional study, we went in with the trend guidelines. So the trend item described here was the title and abstract, that is the information on the target population, interventions, objectives, and study design was clearly stated in this article. The background, the scientific background and explanation of study rationale was stated. Eligibility criteria of the patient's recruitment procedures, settings, and the locations were described. Details on the interventions administered, including the content, the delivery method, the duration, the dose, and the scheduling was also clearly reported. The specific objectives and hypotheses were stated. Clearly defined primary and secondary outcome measures, methods of measurement, timing of the assessment. The sample size, explanation of the sample size determination and the power calculations or pilot justification was not given. The assignment method, that is the unit of assignment, method of assignment, and the methods to minimize the bias was given. Whether participants were intervention providers and the outcome assessors were blinded, they were not blinded in this study, so it was not reported. And statistical methods used to compare the groups, adjust for confounding and handling missing data was given. The flow of participants through each stage, the enrollment, allocation, follow-up, and analysis was partially fulfilled. This is because we are not sure, though the patients who were taken for in the inclusion criteria, those who are compliant, we are not assured of how compliant they were and whether they were using refrigerated insulin drops. Then the recruitment was fulfilled. The baseline data, demographic and clinical characteristics was reported. The number of participants included in analysis with exclusions were given. The outcomes and estimation, that is the result for primary and secondary outcomes, the effect sizes and the precision was mentioned. The ancillary analysis, that is the subgroup analysis of each etiology was not mentioned. The important adverse effects or unintended effects were only partially discussed. They were just mentioning about the mild irritation, but they did not discuss about the other adverse effects and unintended effects in the study. The interpretation considering study objectives, limitations, sources of bias, and imprecision was mentioned. External validity of findings, applicability to other populations or settings, that is the generalizability was only partially fulfilled because this is an Indian pilot study involving only 22 eyes. So this cannot be taken as a generalized study. And overall evidence, that is a statement placing results and contacts of the current evidence was given. Thank you.
Thank you, Dr. Snehata. I think Dr. Srini has had to rush for another engagement somewhere. So Snehata, based on this, would you like to start changing the pattern of your treatment? Would you like to clinically implement the findings of the study? I'm sorry.
Snehita, unmute yourself. Snehita, you're muted.
Snehata, it's a fantastic presentation you've made. So please unmute yourself.
Yeah, I'm sorry, sir. Yes.
So a fantastic analysis you've done there. You know, you've actually left me with very little to talk about, but I will be bringing in some pain points. So let's say, you know, we'll be focusing on some of those things.
Yes.
Based on this, based on the findings that you have, do
Yes.
you think that we have evidence enough to say that, you know, we can probably start changing our clinical practices?
So there are two aspects to this discussion. The first thing is insulin is very cost effective when compared to the recombinant nerve growth factor. Considering Indian population, insulin would be a better choice, but we don't have proven results. With just a sample size of 22 or 21, we could not take that risk of prescribing insulin to the patients. And also we don't know the how the insulin mechanism works without refrigeration, what is the storage temperature, because it is a very friable
I
drug
think
which
let's
is to be
stop there.
used.
Let's stop there.
Yes.
You've What you're saying is correct because see, refrigeration and all has already been answered in the previous studies.
Yes.
So what we want to focus on is one, yes, very correctly you've said, it's a small sample size.
Yes.
It has multiple etiologies.
Yes.
Each etiology is not having adequate power for us to really start making because it's multiple etiologies, we can generalize the results of the study onto other populations, right?
Yes. Yes.
There are certain problems that we have with the statistical analysis, one of which happens to be the multiple t-tests. You see,
Yes.
whenever we are teaching statistical methods, and if you go back to my book, we always talk of avoid the multiple t-tests. There are n number of ways of doing it, and
Yes.
what happens is the larger number of comparisons that you have, the greater is the chance that you will pick up a spurious association. Fortunately, here, you know, it is more of a descriptive study. It is
Yes.
just reporting the results without a control group. So
Yes.
first thing is this is more in the nature of a pilot study. I like pilot studies because what do they do? What do pilot studies give you? They give you food for thought.
Yes.
They help you generate
I see these bigger
more
studies.
what?
Randomized control trials we
Yes.
can go in for with pilot
Yes, so
studies.
they help you generate more hypotheses. So it's a
Yes.
fantastic study, but based on this study, and given the fact that it is a small, then we also look at the regression analysis there. You look at the regression analysis, the numbers are small, and because the numbers are small, what is going to happen is the variance is going to be very large. When the variance or the standard deviation is very large, it is very difficult for us to really get high quality results out of that data. So the take home messages are yes, it is useful. Is it time for us to change? No. Yes, early adopters may adopt it, but we do not have adequate evidence for us to say just yet that yes, we need to change clinical practice based on the findings of this study. Dr. Anagav, Dr. Ramesh?
Yes, yes, sir. So you were right on dot in the sense that, yes, a great pilot study, especially with the etiology being so diverse, uh, future studies where you sort of look at one specific etiology and try to sort of look how we can design a study around it, possibly will give us better roadmap and better understanding of how actually it works. We were just having a food for thought as, can the epithelial sort of a defect or this one this created during a PRK or during a vitrectomy, can they actually be helped by insulin? But we do not show. We are not. Nothing is very clear as of now. Okay, because most of whatever the studies, the etiologies which were depicted were sort of based around a neurotropic pattern. Yes, as you rightly said, yes, we need a better study. Obviously, the population of PED is less. It's not possible by a single center to have this. If they actually plan a much multi-centric trial where you have a large size number, possibly subcategorize it and control. There's only one study which controlled autologous serum. One was the autologous serum versus this. Maybe in India, if we do the same study, extrapolate it, have two arms, and have a larger population, yes, I think it's going to sort of make a meaningful impact in the clinical practice.
Yeah, and autologous serum, if you remember, it had a lot of recurrence.
It had a lot of recurrence. So that's the only thing there in that study. And interestingly, he included infective ulcers. We are not sure what stage of infective ulcer was that. Strange, but we can control it better by having a proper inclusion criteria to define. We published recently, maybe 2 years back from JIPMER, again, use of autologous serum. It was in, I think, 4 to 5 weeks was the healing time. Okay.
Yeah, see, because of that infective keratitis aspect of it, the duration of treatment is longer in those studies.
Yes.
Wherever they have included infectious keratitis. So that,
Yes.
that is what we had. There was a particular debate which was going on long time back. And that, whether to be taken as a confounding factor, whether to be, and then what happened was subgroup analysis was showing us something entirely different. So that, of course, was and here, luckily, what they've done is they've got, their definition of the groups is good.
Yeah.
The problem is the numbers within those groups is so small, just because it is a single center study. For a pilot study, it is very good. I
Yeah.
think it is time for people to get together. And
Agree.
in today's world, it is collaborative research which really rules the world.
Totally agree, sir.
So I think we are done with Dr.
Are we done with the first talk? Yeah, very nice
Hi,
discussion.
hi, Dr. Anaga.
Hi.
We say we were
Hi.
missing you. So we're done with that.
Sorry, there were some patients, so I had to
So
just do
it
a
was
OCT and
a
all.
very nice presentation by Dr. Manohar,
Yes,
and she's been grilled
yes.
not so badly. And then we were missing Srini because he had he had to travel side by side, and he'll be joining in.
Okay, okay.
So we can probably move to
Sure.
Anvi.
We'll start with the next presentation. Yeah. So yes, I'd like to now invite our next presenter, Dr. Janvi Vadhavan, who is a primary DNB resident, BMA HV Desai Eye Hospital, Pune, and her mentor, Dr. Atul Hegde, who is a senior consultant of General Ophthalmology and Cataract Department of the same hospital. So welcome both of you, and yes, Dr. Janvi, you can please go ahead and start your presentation.
Thank you, ma'am. I hope my screen is visible.
Yes,
Yes.
yes, it
Yeah.
is. Full screen, please.
Full
Yes.
screen.
So good evening, everyone. I'm Dr. Janvi Vadhavan, a junior resident at PBMS HV Desai Eye Hospital, and I'll be presenting my article under the guidance of Dr. Atul Hegde, sir, a senior consultant at PBMS HV Desai Hospital. So the study under discussion is effect of capsular tension ring on toric IOL stability and visual outcomes in cataract patients with high myopia. A cohort study including 2 types of toric IOL published by Yilin Sun in the Journal of Cataract and Refractive Surgery with an impact factor of 2.6. So the purpose of this study was I'm unable to move my slide.
You can probably stop your video stream.
Okay.
And,
Yes.
And now press next.
Yes, sir. I'll try that.
I think in future what we can do is we can have one copy lying with the technical team, so that yeah, now you move.
Yeah.
Great, fantastic.
Yes, thank you, sir. So the purpose of this was to assess whether implantation of a capsular tension ring at the time of toric IOL implantation improved post-operative IOL rotational stability, decentration, tilt, and visual outcomes in eyes with high myopia, that is axial length more than 26 millimeter. The study design was ambispective cohort study, and the duration was from October 2020 till September 2024. The study was conducted at Shanghai 10th People's Hospital, Tongji University School of Medicine, Shanghai, China. And it was in compliance with tenets of the Declaration of Helsinki. The sample population were patients with axial length more than 26 millimeter. The sample size consisted of 90 eyes of 68 patients, and the patients were divided into two groups. The first group consisting of CTR implanted with toric IOL, the CTR group with 55 eyes, and the second group consisted of independent toric IOL, the control group with 35 eyes. The two types of IOLs used were Acrisoft toric IOL, manufactured by Alcon with C-loop haptics, and the other was AT Torby 709M toric IOL, manufactured by Zeiss with plate haptics. The inclusion criteria were high myopes with axial length more than 26 millimeter who underwent phacoemulsification surgery with simultaneous implantation of one of the two types of toric IOLs, while the exclusion criteria consisted of corneas with irregular astigmatism, iris abnormalities, or pupillary deformations. Any history of previous corneal or intraocular surgeries, any pre-existing ocular conditions such as uveitis, retinopathy, macular pathology, glaucoma, or corneal disease. Any intraoperative complications including posterior capsular rupture, zonular dialysis, and a cornea with endothelial cell density lower than 2000 cells per millimeter square. All the patients went a comprehensive preoperative evaluation. The IOL Master 700 and Barrett 2 formula was used for IOL power calculation. A digital navigation system, Alcon GPS wavelight system, was used to mark the IOL axis, capsular axis, incision, and site of the size of site of incision. And the patients were allocated to both the groups based on surgical decision and not randomized. The follow-up period was still 3 months. The outcomes evaluated were rotational stability, decentration, tilt, visual outcomes, and the toric IOL axis was measured with slit lamp under mydriatic conditions. Decentration and tilt were measured using the Fourier domain swept source OCT, and these were measured separately both in horizontal and vertical directions. The magnitude and direction of decentration and tilt was calculated based on spatial vector calculation. Statistical analysis was performed using SPSS 26. Continuous variables were expressed as a function of mean or median. Intergroup comparisons after normality assessment through Shapiro-Wilk testing was via t-test or non-parametric test. Multivariate analysis and generalized estimate equations were also used. Chi-square tests were used for categorical data, and survival outcomes evaluated through Kaplan-Meier analysis. A p-value of less than 0.05 was considered statistically significant. So coming on to the results, which were assessed at both 1 week and at 3-month follow-up. So as we can see that the CTR group showed significantly lesser rotation and lesser rotation of more than 10 degrees as compared to the control group. However, this was no longer significant at 3 months follow-up. However, at 3-month follow-up, the decentration in the CTR group was significantly lower and there was no difference in tilting noted. This is the Cartesian coordinate plot showing IOL decentration and tilting at 3 months. As we can see, this will help us analyze the direction and magnitude of IOL movement. The orange dots signify the CTR group and the blue dots signify the control group. As we can see, there is a tight clustering in the IOL decentration group, especially for the orange dots, that is the CTR group, which shows that the results are significant there. A forest plot was used to evaluate the multivariate analysis with generalized estimating equations for parameters such as female gender, axial length, anterior chamber depth, lens thickness, white to white, implantation of CTR, plate haptic IOLs, and age. This was compared against the risk of IOL rotation for more than 10 degrees. As we can see that the use of CTR significantly reduced the risk of rotation for more than 10 degrees. Plate haptic IOLs were associated with the higher risk of rotation as compared with the C-loop haptics, and increasing age was considered as a protective factor as it was leading to less risk of rotation. Subgroup analysis was done for both axial length and the type of IOL implanted. So for axial length more than 30 millimeters, we can clearly see that at the initial follow-up, that is 1 week, there was lesser rotation in the CTR group and lesser residual astigmatism in the CTR group at 1 week follow-up. Similarly, on the left side, we are able to assess that plate loop haptics with co-implantation of the CTR showed lesser tilting of the IOL. These are the survival curves using Kaplan-Meier analysis of rotation of more than 10 degrees. And this clearly shows how the CTR group is showing a longer survival, that is less degree of rotation as compared to the control group. So the strengths of the study were that a high-risk, clinically important population was selected, that is high myopes, and particularly with axial length more than 30 millimeter, where toric IOL instability is most problematic. The use of objective imaging to assess IOL positioning, such as swept source OCT, provided accuracy and reduces subjective bias. Subgroup analysis increased clinical value, and especially the inclusion of 2 different types of IOLs, which is not done in any of the many previously performed studies. The use of multivariate modeling, generalized estimate equations accounted for a repeated measurements and multiple confounders. So this helped strengthening the conclusions by adjusting for factors such as age, IOL type, and other factors. The limitations of the study were a non-randomized design. So this created a potential for selection bias, limiting the ability to infer causality. Similarly, a smaller sample size and irregular distribution created a reduced statistical power and increased the risk of type 2 errors. The short follow-up, that is just for 3 months, may fail to capture a late rotational instability, long-term tilt, decentration, and effects of progressive capsular fibrosis. There can also be a possible observer bias due to lack of blinding, as post-operatively, it was not mentioned whether the observer was aware or unaware of the CTR implantation. So the conclusions from this study were that the advantages of CTR were more pronounced in eyes with extreme axial elongation, which showed significantly lower early IOL rotation degree and residual astigmatism, and delayed occurrence of rotation. Co-implantation of the plate haptic IOL with CTR showed less post-operative tilt. C-loop IOLs outperformed plate haptic designs in rotation resistance, and advanced age independently reduces rotation risk. Now, trying in an effort to assess the study using the MARI checklist, we have concluded that the study design, ambidextrous non-randomized cohort study, was adequate. The study hypothesis was well defined. The study duration, that is October 2020 till September 2020, was also adequate. The study population selected was significant. The sample size, however, small and unequally distributed, provides us with limited statistical power and is modest. The process of non-randomization and unequal allocation creates potential for selection bias, and lack of masking creates the problem of a subjective bias in the results. The outcomes that were assessed were relevant. However, as slit lamp photography was used as the however, this is a standard method, but there can be subjective variability present in this method. Decentration and tilt were measured by swept source OCT, and these were highly accurate, objective, and reproducible. The follow-up period is considered to be short. The results, the statistical methods used to obtain the results are appropriate and well matched to the study design. Additional benefits were the utilization of multivariate analysis, generalized GEE analysis, and subgroup analysis. So the interpretation, there were various studies that have been mentioned that showed association and consistency with our results. This proves that this study was clinically relevant, but causality remained limited by study design. And coming on to the extrapolation of the data was applicable to similar high myopes, monofocal toric IOLs, but not to multifocal EDOF or long-term follow-ups without further data. Thank you.
Very nice presentation, Dr. Jahnavi. I think it's a very good article that you have selected, and it's a very it's pertinent. It's important that we analyze this article in uh, with uh, with the proper scientific tools, right? So based on this, what are our take-home messages, first of all?
So the take-home messages were how CTR implantation is especially beneficial in high myopes, where there is a lot of instability due to zonular laxity and various other factors that are producing this instability. So CTR co-implantation is helpful. The other important take-home message was the application of different types of IOLs. A lot of previous studies that I came across were performing the study with just one IOL. So that cannot be generalized to the entire population. These were the...
I think you're right. What you're saying basically is that you see what the study says is that probably in very high myopes beyond 30 millimeters, that is where the CTR is giving us good results. And because the plate haptics better with the plate haptics than with the C-loop haptics, because C-loop haptics, wherever you have a variability of the bag size, the C-loop tends to adjust a little better, right? So far as the limitations of the study are concerned, I have a few, I am slightly circumspect about it. I see Dr. Hegde coming in.
Yeah,
For
yeah,
this study,
yeah,
it raises a lot of questions, actually.
yeah.
Your take on that, sir? Because I would be coming back to the good thing is they've used generalized estimating equations, which how that helps is because it solves the problem of what we call multicollinearity.
Yes, sir.
Wherever
Yes.
you're using linear generalized linear methods, multicollinearity we have to test in the residuals. Here you can do the repeated measures, which is what is happening. So that is the biggest strength of the analysis that has been performed.
Yeah, yeah, yeah.
And sir, there was something that you were about to say.
No, no, it's the same thing. So the limitations and the strength of the study.
Yeah, it's
Yeah.
and so far as unequal sizes are concerned, yes, we can
Yeah.
do unequal sample sizes also.
Yeah, the sample size was not equal. That was a limited, very big limitation, I think.
Yeah, that's a limitation, but there are ways and means of we can do it with unequal sample sizes also. That's what I was coming to with the Jahnavi. And sir, actually, I had a couple of I was looking at this. Could we come back to table one, Dr. Jahnavi? Could we
Yes.
share screen again?
Yes, sir.
So now I'm going to ask her to analyze the thing.
Yeah.
So which slide should I open?
Table one you have shown me on one of the slides. So, sir, what is written and what is no? Let's go backwards.
Coordinate map
Backwards.
table.
Yeah.
This
So this
one.
is your table one. Okay.
Mhm.
Now
Yes.
let's look at it. Let's look at it in full screen.
Mhm.
The first one, you see what is happening here is Y rotation of more than 10 degrees. That is the clinically significant rotation, right? Now,
Yeah.
what is happening here is in clinically significant rotation, at 1 week, you find that it is significant.
Yes.
At 3 weeks, it is not significant. And what is happening here is the change in the CTR group is more. You look at the control group, which is the non-CTR, that goes from 12 to 16. The CTR group goes from 12 to 18.
18.
So basically, what we say in where we've masked it, saying that it's a small follow-up, we'll go back to data. The data will speak further. Here it seems to suggest that the CTR group, because once the fibrosis starts setting in, the
Yeah,
CTR group may not be performing very well over
very
the
well.
entire subgroup, over the pooled analysis, right? Then we don't have decentration data of the first week. We don't have the tilt data of the first week, right?
Yeah.
We do have it at we do have it at 3 months. Now let's go to the next one where we have those figures. Next one, next one. Okay. Now here, if you look at, uh, let's go to the first one. Let's go to G and H on this side,
The IOLs or the axial length?
the axial length.
G
Okay.
and yes.
Now you look at the decentration and tilt data on the axial length,
Mm.
and you will realize that it there this is all this is a skewed. The control group is a skewed group at 1 week, and it starts becoming a balanced group at 3 months.
3 months.
The CTR, the stability is much better at one week. At 3 weeks, you suddenly find that there is a skew on
Yeah.
one side,
Mm.
right? So less than 30 weeks, we find that there's no difference between uh,
The
the
CTR group.
decentration and tilt, right?
Yeah, yeah,
We do find that there is a benefit when it is more than 30 millimeters, the axial
yeah.
length. Now look at what happens. At the first week, you have a skewed data. It has a long tail on this side. Long tail. The control group has a long tail on one
Yeah.
side,
Mm.
which starts reducing at 3 months. The CTR group, you find remains, it is one group. It is distributed well. It is not abnormally skewed in one direction, and it starts moving upwards. This is in age. At 1 week, you see the CTR group is lower, and at 3 months, you suddenly start realizing that it is going higher,
Yeah.
right? So that is why we want to go and see the 6 months data, the 1 year data in more than 30 group, right?
Yes, yes.
So do we want to make changes in our approach? As yet, the answer is no. It
No.
is inadequate data points. Now let's come to the C-loop haptics versus the plate haptics, right? Let's come down to G and H again here. This is there. This is mentioned there also. Now look at the control and case in C-loop haptics at 1 week and at 3 months. You find both of them are rising. Uh, you, control has to be compared to control and case to case,
Yes, yeah.
right? So now you have to compare this with this and control with control, and you find that both are rising. They are showing an increasing trend, but more in the CTR group. And when you look at the plate haptics, you find that the plate haptics, it is performing better, but the data is becoming skewed in the CTR group
True.
at 3 months with the plate haptics.
Plate uptake.
So once again, you want to, and mind you, this is statistically significant difference. The p value is 0.005.
Yes,
So you
sir.
want to again go on and check how it behaves at
At
6
6
months
months
and 1 year,
and 1 year. Yeah.
because it is moving. You see, both of them are moving,
Mm.
not by the one of them remains stable. The control group is stable. Look at the decentration and tilt data at the control group, and then so because with the CTR group there are changes which are taking place at 3 months, it is probably inadequate follow-up, right?
Yeah.
Now, of course, then when we talk of causality, there are 5 or 6 things we need to look at. One is, of course, biological plausibility. Then how well it is repeated over multiple observations. So as yet, I think it's a very nice study which raises questions, but unfortunately, it is, we still need to analyze the data. We need more
Further.
data.
Yeah.
So it is a very good study in terms of a discussion. In terms of early adopters, yes, they can try the 30, more than 30 millimeters of mercury if the more than 30 millimeters, if your axial
Axial
length
length.
is more than 30 millimeters, go in with a CTR, probably a good recommendation. But yes, we do need more data on this. And there are other things that we can talk of in the Cartesian analysis also, but broadly those are now the third thing most importantly is whenever we are looking at ambispective studies, you see this is an ambispective study. Some
Yeah.
data is it has already been collected by either you or by somebody in the past, and then some of it will be collected in the future. Now, it is very important to ensure that the quality of data is similar. The older data is comparable to the newer data. And that is a very big challenge. And, you cannot compare apples to oranges. What happens with ambispective studies is if there is a protocol being followed, yes, it is possible to get good quality data. But a lot of people, what they do is they pick up data from EMRs, and in EMRs there is uh, a lot of errors have crept into that. So that is where we have to be slightly, skeptical about generalizing the data from that. What do you say, sir? Dr.
Yeah,
Hegde?
yeah, yeah. I completely agree with you, sir. Whatever analysis you did regarding this study, the follow-up is very short, sir. I also agree to that point. The follow-up should have been done for 6 months or 1 year.
Or others are going to do it.
Yes, yes.
And but very well presented, both Dr. Jahnavi and Dr. Snehita. And I will congratulate both the mentors, Dr. Hegde and Dr. Ramesh. Dr. Ramesh, would you like to comment, sir? I think we've lost Dr. Ramesh.
We have lost. Yeah, he may not.
Yeah, we've lost Srini again is traveling, and Dr. Anaga is there, so we can
Hi,
continue. Yeah.
hi. Lovely presentation and lovely discussion. Really nice. I think this is so important, when you discuss it in so much of detail. Great, Dr. Jatinder sir. You
Oh,
have
thank you
done
so
a
much,
great job
ma'am.
today.
And
Yeah.
thank you
Very,
for
very nice.
indulging
Hi,
me.
Srini,
Hey,
you're
Dr.
back. Yeah,
I'm in the train now.
Ah,
Okay.
Srini is back.
Yeah,
Tiger
no, no,
Zinda
no.
hai.
Dr. Bali, sir, wonderful discussions. It was great. Like you
We
dissected
missed
that
you. It
also.
was Toric IOLs. And if
Yeah.
there's somebody who really talks Toric, it is Srini.
Yeah, yeah.
Toric
Yeah,
and
We would like to.
multifocal.
and I actually don't want to disturb my co-passengers. Okay. Well,
Why we understand.
yeah.
Dr.
yeah,
Hegde.
yeah. So thank you so much.
Right.
Yeah, yeah, yeah. So I'd like to thank each one of you, all our discussants, Dr. Jatinder especially, for taking it, for both the presentations, our presenters and our mentors.
Remember,
Thank you so much. Thank you to our AIOS president and Dr. Prashant, our ARC chairman. Yeah,
yeah,
you
Dr.
were saying
Prashant is
something?
doing a fantastic job of it.
Yes, yes,
And
absolutely.
frankly, I'm so happy to see the quality of papers and the way they are discussing it. I think Dr. Anaga, hats off to you. You people have brought ARC. It is actually the academic and research committee is doing wonders.
Thank you so much. Thank you. And thank you. It's only because all of you are there to support and to participate in it. And I really wish all the PGs really listen to this and, gain more knowledge out of this. Thank you so much, everyone.
Thank you, ma'am. Good night.
Okay. Thank you,
Thank
ma'am.
you.
Day.
Thank you, Dr.
Thank
Bali.
you,
Bye.
everyone.
Yeah.
Thank you. Bye. Thanks.